the recording, I'd like to officially welcome everyone to the Misophonia Professional and Academic Collaboration Workshop number 3. You go ahead and start with Dr. Randall Lyle's presentation, Misophonia Searching for a Treatment. Randy is an associate professor and in Marriage and Family Therapy program at St. Mercy University in Iowa. He has his own practice and has been using neurofeedback for almost 20 years now as part of that practice. And so, Randy, I'm going to go ahead and turn it over to you at this time.
All right. Well, thank you, Tom. And hello to everybody. It's a pleasure to join you all and talk a little bit about misophonia and neurofeedback. As Tom mentioned, I've been at Mount Mercy University for about 6 years now. Prior to that, I was a program director of a marriage and family therapy program, both doctoral and master's program in San Antonio, Texas. While there, I created a subspecialty for training students to provide neurofeedback services, and we created a clinic out of the university. So I've been doing neurofeedback and teaching it for a fairly long time now. I guess it's been about 4 or 5 years ago now. Shortly after I moved to Cedar Rapids, I had a fellow come in for therapy. Specifically, he wanted to try neurofeedback. His initial complaint was that he had a touch of what he described as OCD. And he thought that his son probably suffered from it as well, and so he was going to test it out on himself and see if neurofeedback would offer anything, and if yes, then he was going to invite his son to take part in it as well. Well, as we got going and got to know one another, it turns out that what he was in fact experiencing wasn't simply OCD, he was experiencing misophonia. And as we get into the case studies, we'll see that he is one of the case studies, and in fact, my first and most successful case. His son also suffered from it, and I also trained him for misophonia, and that set me on a journey that lands me here with you all. Little did I know that I was going to end up being one of the foremost experts on the use of neurofeedback and misophonia in the United States a few years later, which is not to say that I'm any kind of expert at all. It just says that I'm one of the few people who's been doing it for a while. The slides represent a study that I've completed, completed enough to write a paper and submit it for publication. I presented it at ISNR, which stands for the International Society for Neurofeedback and Research, this past year. So we've opened the door by getting the word about misophonia out into the neurofeedback community. They have a meeting once a year. There's usually between 600 and 700 people there attending. They range from MDs, neurologists, to therapists, psychologists, a whole wide variety of people who are, for the most part, interested in or doing neurofeedback. The presentation was well received with lots and lots of questions. Lots of people coming up to me after the presentation and saying, "Oh, yes, I'm treating people. I have people who have been coming to me with those issues, and now I know more of what it is and what to do about it." The year before, Miriam Edelstein, and if any of you have read the literature, know that she's one of the first people to really look at it from a neurological perspective. She works at V.S. Ramachandran's clinic out in San Diego, which I think is extraordinarily exciting for the misophonia community, because Ramachandran is probably one of the foremost neurologists in the world. And if his clinic has become interested in something, that means that he can generate some income and some excellent research. So I'm optimistic that we may find out some new and interesting things here in the future. To just kind of briefly go over the study, give you some ideas about what it is and what we did. Quantitative research is the research that most of us are familiar with. It's putting numbers to things, operationalizing the data, limiting all of the confounds and all of that. So it's the stuff that we're most familiar with. Qualitative research, which is actually my preference and what I do the most, is actually talking to people with, or people who have or are interested in the phenomenon that we're seeking to understand better. In this case, we did a combined methods study. So we looked for quantitative data by recording the quantitative EEG of the 3 people that are reported in this study. I then got additional EEGs from around the United States for other folks who suffer with misophonia but weren't in my practice. The qualitative component is sitting down and talking with 3 of those people that I've treated here and asking them to describe what was your symptomology, what was your experience of neurofeedback, how did it help, what was the process like, and we'll look at that a little bit as we go along here. We probably are still in the process of trying to define misophonia. These are a couple of definitions that have been offered, one of them from Edelstein, who I was just talking about a minute ago. Again, Edelstein's study was one of first sitting down and talking to people and asking them to describe what misophonia is. From those descriptions, a common definition for misophonia is, as she says, a quote, a strong dislike of certain sounds and an abnormally strong reaction to them, such as anger or even fear. I'm imagining that several of our participants that are listening today are people who suffer with misophonia, so you probably have your own definitions that you can give to that in much more detail. As we've learned more about it, going around listening to people and having people call me up to say, I'm treating somebody with neurofeedback with misophonia, can you help? It is much like a spectrum disorder, kind of like autism or others. You can have a little bit of misophonia or you can have a lot, it seems. So you can have some people who experience it, they find it frustrating and challenging, but they're able to go about their daily lives without too much effort. They find ways of coping with it. And then you have people who in fact are not leaving the house at all, or even worse, have attempted or completed suicide because the problem is just the response is just too much, and they just simply are not able to do it. This particular slide talks about that as we've examined misophonia as it's sort of become known, we find that because of those responses, it's received a variety of definitions and descriptions, ranging from OCD or PTSD, social phobia, intermittent explosive disorder, etc. That's still very much the case. If you go to a psychologist or others who are not familiar with misophonia, you stand a very high likelihood of having a misdiagnosis where you will be described as having one of those disorders, and then being recommended treatment for those disorders, which more often than not is going to be medication. Medication is not proven to be useful except for some moderation of some symptomology, but even that not particularly grateful or great as so far as people have reported to me anyway. Coherence is one of the measures that we looked at as we recorded the EEG. I should probably say something here about what quantitative EEG is, or QEEG as it's called briefly. QEEG is doing what would be a typical clinical EEG, just like you would get at the neurologist's office if you had a car accident or you were experiencing the symptomology of seizures or some other reason for them to look at what's going on in the electrical activity in your brain. We put 19 electrodes on the head, and we measure all of the electrical activity from those 19 locations in real time. We usually do it in 2 different conditions, one with eyes closed, the other eyes open, because our brains may work differently between the eyes open and the eyes closed. We then take that information, we clean it up, and we don't look for the same kinds of things that the neurologist would look for, spike and wave activity indicative of epilepsy or other things. Rather, we clean it all up and get rid of any of those if they are there. We then compare that to a norm database. So we have several thousand carefully recorded EEGs from people who were carefully screened to make sure that there was no brain disorder of any sort. We then compare that individual's recorded EEG to that norm database. And that then tells us in 4 different domains what is normal, that is, say, what falls within a statistical norm, and what is not normal, what is outside of those statistical norms. One of the domains in which we are able to look at that normed or not normed is coherence. I describe coherence as your brain talking from one region to another region. So the front of the brain talking to the back of the brain, or the right side talking to the left side. And if we think of that in an analogical terms as sort of a telephone call, coherence can be the telephone call normally would go right through the other, wherever you're talking to that other part of the brain in order to complete your connection and be able to do what you want your brain to do. That's how it should work. Sometimes in hypercoherence, the message is getting through so fast that it's garbled and the connection doesn't really get made. At other times, in hypocoherence, it takes so long for the message to get to the other connection that by the time it gets there, they've already hung up. They don't want to listen to you. So hypo or hypercoherence means that the brain cannot, in fact, do what it needs to do because it cannot communicate with the different regions, which is indeed how the brain works. So this simply explains that, with coherence, we did the measurements as we would. We explained all of the details of that. We took all of that recorded information. We cleaned it all up. We ran it through the database and compared it. We used the NeuroRep software to look at a multivariate coherence analysis system rather than a simple ANOVA, or a very simple basic comparison. This was a more complex and more in-depth way of examining the coherence measures. This would be the kind of map that you would get. This indeed is the overarching map. When you put all of the EEGs that we evaluated together, you get this sort of map. And if you imagine, if you can put the brain or a skull around these top ones, the horizontal, sagittal, and coronal, then you're looking at how at all of these electrode sites the brain is connected. The more closely packed together they are, you have hypercoherence. The more distant they are from one another, the more you have hypercoherence. So we can see then in general terms that there are some discrepancies here. There are some areas of the brain that are quite closely packed. Some regions, in fact, just kind of disappear. You can't even see them. They're so closely packed together. That tells us that there's some dysfunction going on there. There's some hypercoherence going on. The lower heads are then the exact numbers that are measured in that, which are relative to the software. So this map simply indicates for us that globally, yes, we have some indications that coherence is at least nominally involved in brains that experience misophonia, that it's not working quite right. Now, that does not give us causality. We don't know that that's the cause of the misophonia symptom, but we at least know that there tends to be some dysfunctions in the measurement of how well the brain is communicating across different regions. These particular ones resulted from 5 records that were from my practice and 4 additional records from other providers around the country. So we had a total of 9 EEGs that we fed into the comparison. We visually compared all of the different coherence steps for all 9 subjects. There was no common pattern. So there was, they weren't all the right side of the head talking to the left front part of the head or something like that. There was no clear pattern of commonality across those measures. What we can say, as I just pointed out on the previous map, we can say that there is a tendency for all of those brains to have problems with coherence. We just simply didn't find that they all had the same problem in the same region. My interpretation of that for our purposes is to say that, as we know, misophonia operates on a spectrum, It is not a singular brain problem. That is to say, it's not like, oh, it's always going to be related to this region of the brain in this particular domain, but rather different regions of the brain are going to be differently affected, and that's going to be probably be reflected in how people experience the symptoms. More severe, less severe, what kinds of sounds are more problematical for them, those sorts of things. Now, the second measure that we looked at in order to try and get our quantitative data is something called Loretta. Loretta stands for Low Resonance Electrotomographic Analysis. It is a technique that was developed over many, many years and much effort by an Italian physicist. And what it allows us to do is to record the activity of the brain at the surface, and through mathematical transformations, discern from that information where inside of the brain signal problems are arising. This was a great, huge step forward for us in terms of understanding and treating with neurofeedback brain disorders. Prior to the integration of Loretta into neurofeedback, all we could do was really train the strength or the type of signal at the surface. We really had no idea what was happening below the surface of the brain, nor how we were affecting it. We now can find out, oh, this signal is coming from somewhere in the subcortical structure, and we can continue to record and analyze that data and say, oh, we've done something to that, and it was something we wanted to do. So that's been a great stride forward for the neurofeedback community. This is a whole lot of information that's probably really, really important for peer-reviewed journals and scientists. If there are any of that, you can read it at your leisure and certainly send me an email or whatever to ask me more details. For most folks, it's not really all that interesting. I'm not going to go over it except to say it's here and you can look at it and look into it in more detail. Again, this is more specific detail about how EEG, how the Loretta works. I don't think you want to know about that. These are the details in terms of the statistics that we ran. Again, really important for the scientific community, not particularly important for consumers. And it just says, you know, should someone want to replicate what we did, these would be the things that would be important to continue in this study. This is an overall map reflecting the results of all of the studies, all of the EEGs that we combined in order to look at in generic terms across the board, do we see anything significant? What we discover here, and we'll talk about it in more detail here in a second, is that indeed here the red and the yellow reflect some excess activity in these particular regions. So this is a model of the brain. We see this is the back side, so back here in the parietal and somewhat to the occipital regions, we see an excess of activity, specifically at this frequency 8 hertz or in the alpha frequency. We also see there's some excessive activity along the midline towards the frontal part of the brain, and a little bit on the sensory motor strip. And then we can see this from all the different angles, right, left side, looking from the top, looking from the back, in order to localize that to the brain. We see, again, the same thing reported, but now we're looking at 6 hertz. And so we can see that there's, again, some activity, particularly in the right occipital and parietal regions, up here on the parietal regions, this region, here on the right side, here left frontal. So we get some idea that, yes, from a Loretta perspective, there does seem to be some presentation of dysregulation. That is to say, there are areas of all of these brains that seem to be out of the norm, outside of the norm, statistically outside of the norm. And then we look at those specific regions and say, do those make any sense in terms of the symptomology related to what is reported with misophonia? And so here we see that the compiled files and eyes closed both all showed slower frequencies than delta and theta, that is to say the slower waves, and beta frequencies in the parietal cortex, so towards the back. Parietal cortex is all about our sense of our body internally and externally. That is to say that I have a body, I'm aware of it, I know how it works, and I'm aware that I have a body and it's in relationship to other bodies. That information is all being processed in the parietal cortex, and then of course all of the other environmental data that's coming in. So we would say that probably makes some degree of sense, that the parietal cortex would be having some challenges and not be working appropriately would make sense to us in terms of the symptomology commonly associated with misophonia. And that maximal localization is in Brodmann area 7 and in specifically in delta and theta. Here, as we say, Brodmann area 7 is involved in the visual motor coordination and contributes to the variety of high-level processing tasks, including activation and association with language use. Only with eyes closed condition did we notice that the alpha band is focal in the medial frontal gyrus of the frontal lobe, specifically Brodmann area 9, which is involved in short-term memory, error detection, sustained attention, auditory verbal attention, and other executive functions. So again, does that make sense to us in terms of the presentation of most misophonia symptoms? We can at least somewhat say, yes, that makes sense, particularly executive function. I hear a noise, I recognize what that noise is, I perhaps see it. What should I do about it? Well, if somebody's chewing their food across the table from me, I should probably ignore it. At worst, say, close your mouth, you're chewing too loudly, particularly if it's one of my children. Instead, I go into a rage. So there's clearly a problem. I have some auditory functioning going on, but I don't seem to be able to discern the appropriate action or control that. So Loretta tells us that at least tentatively, there is some reason to suspect that brain function, particularly at a sort of subcortical level, is related in some form or another to the experience of misophonia symptomology. So again, the summary of the quantitative part of the study is that we got some anomalies, we got some ideas that there were some potential problems in these brains. We did not find anything that was consistent that each individual, all of those 10 EEGs had. So yes, they all had something. No, it wasn't always the same thing, but there was some inclusion in certain regions, which we just talked about. Qualitative study, this is kind of more interesting to me because as a therapist, I'm more interested in people than I am in numbers. So the study looked at specifically 3 people that were willing to participate in the study, 2 males, 1 female. The female is 13 years of age. The 2 males were both in their mid-60s. All 3 of them received a combination of traditional neurofeedback, which is to say we trained specifically amplitude and frequency in just a single region of the brain with just 1 or 2 wires as a general rule. Sometimes we do 4-channel and move it up, have 8 wires on there. And the Z-score Loretta feedback, which is doing all 19 channels simultaneously and training all of the different domains. Through subjects is subject 1, she's 13 years old, female, or she was at the time of the study. Onset was at age 9. Her major triggers were gum chewing, eating, especially with her father and brother. Repetitive sounds like pen clicking or tapping. She ultimately required homeschooling because the triggers were too severe at school, and she could not eat with the family due to the rages, particularly with her father. At the time of the interview, she'd received 80 sessions of neurofeedback. When we asked her on a scale of 1 to 10, comparing her symptoms at the beginning and where she was now, 1 being totally cured, not bothered by the symptoms, she said that at her worst trigger, gum chewing, she would currently be at a 5. When asked if this 5 was livable when she hears people chewing gum or chips, she said, "It is better, but I still hate it." With all other triggers, like her brother's eating, she claims it is now a 2. However, both she and her mother were quick to clarify that these numbers were dependent on her getting enough sleep, how well she's been eating, and how she feels towards the person. She was still struggling with her father. She's actually just returned to treatment last week. we're just about finished with school, so the plan all along was for her to come back during the summer and do some more treatment. She still finds her dad's eating to be her major trigger, and is still struggling with that a bit, but she is in school, attends school full time, is able to participate fully in those activities. Subject 2, 60-year-old male, onset, as he recalls, around 6, comorbid with OCD, that is to say he also experienced obsessive compulsive disorder. Triggers were gum chewing, lip smacking, loud eating. Triggers were both auditory and visual. He organized his life around the possibility of being triggered, always said at a public occasion so he could escape. Used alcohol for self-soothing, something that we hear about a lot in the area if it's an adult. His wife carefully managed the house activities to try and keep the triggers at bay, and son also suffers from misophonia. While the son did not participate in the study, I did also treat him with neurofeedback and can say something about that. This is the person that I mentioned initially that got me involved in misophonia. He had a total of 240 sessions. He attributed this large number of sessions to his strain of OCD and being a perfectionist. At the end of the day, he just wanted it to be completely gone, so I went to a lot of sessions. According to his report, he said he needed at least the first 160. But when he asked if he felt like he needed this many sessions, he said that he saw some incremental improvement from 160 to 200 and from 200 to 240. He now believes that he is 97% cured. The last 3% is basically just his fear that it might come back. It's not that he actually experiences any challenges with it. Gum chewing is no longer a problem for him. As he said, life is 100,000% better. He also says that he felt some initial results after the first 11 sessions. Part of the clarification with this particular client is that when I started seeing him, I was not doing the Loretta Z-score neurofeedback. I didn't have that available to me. As we continued with his treatment, after about a year of treatment was when I got the Loretta Z-score and began that treatment with him. I think we saw another jump in improvement in his case. I've found that traditional neurofeedback isn't always helpful, and when it is, even if it is, it's a lot slower than the Loretta is. Treatment with his son, who's not, as I noted, is not included in the study. We also had good success with him. He has now gone off and is in college. We did not have as good a success with him as we had with the father. The father still remains my most successful case, where basically he's cured. Son self-rated himself as having between a 75 and 80% improvement in symptomology. Can pretty much do anything. As I said, he's at college full-time, very successful in school, not having any problems in that. Still has triggers, notices them, but just isn't as bothered by them. So he's kind of gone from one of those folks who can't leave the house to being one of those folks who can pretty well manage his life without too much difficulty. Just gets annoyed and frustrated fairly frequently. Subject 3, also a male in his mid-60s. He remembers onset at about age 15 or 16. Primary symptomology was chewing, lip smacking, throat clearing, coughing, loud noises. Repetitive noises like pen clipping or tapping, bothered by both auditory and visual triggers. His misophonia has increased and worsened as time has gone on. 4 marriages ended due to misophonia by his measure, as well as numerous jobs. The last 2 both became self-employed so that they could have more control over their lives in order to manage the misophonia to a large degree. This individual has seen many neurofeedback practitioners and done a whole lot of other things with me. We kind of threw the kitchen sink at him. At the time of this study, we were kind of at the beginning stages of his working with me. We hadn't seen any improvement. And in fact, after a lot of treatment, he never did see any significant improvement in the symptomology related to misophonia. That being said, he did see a lot of improvement in his ability to cope with it, his ability to manage his symptomology was improved, and I think his sense of his quality of life was improved, although we hadn't really done much of anything for the misophonia. So he is my major failure. We continue to hope that we can find a pathway to helping him be have some relief of symptomology. So all of the clients received a combination of the Loretta 19-channel Z-score training and 1 or 2 channel amplitude training. All of these were guided by the quantitative EEG. So we did the quantitative EEG beginning and then regularly repeated it. All of them participated in passive infrared hemoencephalography training. That's PIR-HEG. That is a method of training that was originally designed to treat migraine headaches. It involves shining a specific frequency of infrared light onto the forehead, measuring the change fluctuations in temperature as a result of participating in the training, and rewarding the brain when it's able to activate the frontal lobes of the brain. My rationale for that is that executive function seems to be a consistent issue for folks with misophonia. Executive function would, of course, be my ability to say there's no reason for me to be upset by this, and therefore not be. So I hypothesized that additional training of a variety of sorts of the frontal lobes, which is where the executive control exists or resides for the most part, might facilitate improvement. PIR also requires a whole brain participation, so I was hoping it would be integrative of the other forms of training. I would say the jury's still out on that. I haven't run any numbers on it or consistently integrated it in such a way that I can easily study that. So I'd say the jury is still out. Since we did this additional, when I did this original collection of data, I've had 2 more misophonia clients, and the 13-year-old girl that I talked about has returned to training. They've all reported continued improvement. The other 2 teenage girls, both of them, because by now I have a kind of pattern that I follow, seem to respond more quickly. They all felt that they made significant improvements, and in fact, one completed 60 sessions and is now taking a break from treatment, may or may not come back. The other one reports a 70% improvement, again, is now taking a break and may or may not come back. Their plan was to return, but I'm not sure. I haven't heard from them, so I can't say. So conclusions regarding the study is, as I said, misophonia appears to be a spectrum disorder. It can range from mild to severe. There are a variety of means by which people try to cope with it. For those of you who are suffering and listening to this, or will listen to this, you all know that. You find ways, or you seek to find ways. I would say that neurofeedback is a viable treatment. It is not universally helpful, but then nothing is for anything, as near as I can tell. But it does seem to be useful for a great number of people. It doesn't necessarily cure. In fact, that seems to be fairly rare, but it does make it a lot better and moderates it. And so far, many people are able to report that their daily living is improved. Probably subcortical. You find that in the Loretta findings. May be related to coherence as well, but it's also clearly multidimensional. That is to say, it's in a variety of regions of the brain and a variety of networks and connections. So far, there is no magic bullet or single treatment that will get us to where we want to be. That's probably good. You can read the rest of those. Oh, I will mention the neurofield treatment. If you're on any of the listservs, you will have heard Jamie Moore's name being mentioned frequently in the last few months. Jamie is a registered nurse working out of Omaha, Nebraska. Does do neurofeedback, but also primarily works with neurofield. Neurofield is known as a pulsed electromagnetic field therapy. It pulses tiny amounts of electromagnetic energy. Can be placed on the body or on the head. He's doing a lot of work that's oriented towards physiological issues such as diet, inflammation, those sorts of things, which he's also reporting some good outcomes. There's a couple of people on the Misophonia listserv who are keeping us informed as their children go through the process, and they are experiencing some significant progress as well. I've since integrated neurofield into what I do as well, and I'm hoping to have the opportunity to find out if I get the same sort of increase in benefit by having all of those different modalities available to me. I've got some questions over here I see on my screen. What is the duration of a single therapeutic session, and how frequently do individuals attend for therapy is one question. Duration of a single therapeutic session is about between 35 and 45 minutes as a general rule. I generally encourage folks to attend at least twice a week. At the beginning of treatment, my hunch is with misophonia, if we could get them in more often for a more intensive beginning, every day, for example, for a couple, 3 weeks, we probably could push things towards improvement a little bit faster. Twice a week works. One of my favorite sayings is there's the ideal and then there's what we can do. So for a whole lot of folks, you know, including me, since I have my practice is actually a part-time deal and not this is not my full-time job, that's the scheduling of somebody every day is a challenge. As I reported with these three, 2 of the 3, about 5 out of the 3 that I talked, or the 3 out of the 5 that I talked about have all had improvements. Twice a week will work. Have there been any studies using attentional training, mindfulness as a component of the treatment? I'm not aware of any studies out there. I do talk to all of my clients about mindfulness. I also encourage all of them to take fish oil, omega-3 fatty acids. And I've been increasingly encouraging them to take probiotics as well. Recent research has been clearly making a strong connection that the blood-brain, the gut-brain connection is critical for our well-being and for the well-being functioning of our brain. So increasingly, we're looking at ways to treat inflammation, and neurofield can give us a real hands up on that. So we're integrating that. Mindfulness as a means of helping you to cope has proven, I think, is very useful for the clients that's had no success with the symptomology of misophonia by itself. Getting him to do meditation training, and he in fact went and did some intensive training for meditation, has helped him immensely. Curious if there is any evidence of activity in the insular cortex being implicated in misophonia. It has shown up with the various clients and other EEGs that I have evaluated, but not universally. So again, sometimes indeed yes. It shows up as being an area that is not functioning as it should in the electrical domain. But again, it's not consistent. It is not in every client that we have seen with misophonia.
Randy, there is a question by Sukhvinder Kumar about, that maybe was thrown off your screen, about the variable that you're trying to control with the neurofeedback sessions, power, coherence. What is it that you're trying to have them work and control?
When we do the Loretta Z-score training, we are training all 4 of the major domains. So we're training to affect amplitude, frequency, coherence, and phase. Phase is the means, if you think of Morse code, how one region of the brain tells the other brain what to do is in how it pulses, the speed with which it pulses the electrical signal. That's the measure of phase. So coherence is the measure of the communication between the two. Phase is its ability to do that and say what it needs to say. So we train all 4 of those domains simultaneously across all 19 channels in whatever regions we've highlighted in the software. When we do the traditional neurofeedback, we're primarily just interested in frequency and amplitude. So when we're doing the traditional neurofeedback, those are the 2 domains that we're training. Again, each of those is trained in whatever it is we need to train is in response to what the quantitative EEG has told us is not functioning correctly. That is to say, there's 2 or more standard deviations outside of the norm.
Okay, so we have a request to hear from Satvinder Kumar. Satvinder, I just clicked your microphone.
Can you hear me? Can you hear me?
Yes.
Yes.
Can you hear me now better?
It sounds like your microphone is too sensitive, and it would probably help if you had.
Okay, that's fine, yeah. Well, thank you very much for the presentation, actually. Just a couple of questions, specific questions. So one thing that I didn't get was when you are trying to find out the unique pattern, did you compare it to control subjects?
No, we didn't have any control.
Like I said, Menard, you're still way too loud and you're distorting. So Randy, did you get enough there to answer that first question before I cut him off?
Yeah, I've got at least part of it.
Okay, go ahead, and I'm going to, because we're getting feedback from Satvinder's speakers and microphones, so I'll have to have him cut off when anyone else is speaking. Go ahead, Randy.
Okay. We didn't have any controls to the study. As I noted, this was a pilot study, limited in its scope. Within the quantitative EEG, so when we're specifically training the regions in an individual, we have taken his or her EEG, compared it to a norm database, and then we are training that towards that norm. So each individual is being trained against a control, as it were, but there's no global control for the study. So that's, right now, just trying to figure out, can we nail down what regions of the brain or what domains within brain function are responsible for this, or most commonly responsible, would then give us a means to begin to refine and operationalize things sufficiently to do controls. I don't think we have enough information yet to be able to actually do that.
Okay.
The other, in the neurofeedback, are they trying to? Sorry, I didn't understand that completely. Are they trying to reduce the alpha? Are you just concentrating on the alpha power coherence, and are they trying to increase alpha power, or are they trying to decrease alpha power?
That will depend on what their quantitative EEG revealed. If they are the treatment is customized to each individual. So if they have an increase of alpha, that's what shows up as being 2 or more standard deviations outside of the norm, then we will train them to, I forgot which I said, if it's too low, we'll train them to increase it. If it's too high, we'll train them to decrease it. Same with all of the other measures. So if the quantitative EEG for that individual says that you're experiencing hypercoherence between the front and the back of the brain in certain specific regions, then we will set the program to encourage you to reduce that hypercoherence. So each individual has a customized treatment to the specificity of what we discovered is being problematical with their individual brain. That answer your question?
So Satvinder talked very, very quietly. You have the microphone.
Can you hear me now? Can you hear me?
Yes.
Okay. So how many do you think out of 9 subjects had hypo power in the alpha band and how many of them had hyper alpha power or coherence? Do you have some statistics related to that?
I can't really break that down off the top of my head by individuals. What we saw in the overall findings of Loretta was that if I don't remember, I can go back. Here and look. So in eyes closed, resting condition only, the alpha band is focal in the medial frontal gyrus of the frontal lobe, specifically Brodmann area 9. Theta, and that only occurred in the eyes closed condition. Theta and delta were the two areas that were most, were the two frequencies that were most involved in the eyes, and both eyes closed and eyes open conditioning across those 10 EEGs. But I can't tell you how many of those individuals experienced either of those. That, you know, these are just the summative numbers of that.
Okay, before I give the microphone back to Sukhbinder again, if anybody else would like to ask a question, to speak up, there's a little hand sign up at the top of your screen somewhere that it's a raise my hand with, you know, with something like this. And so just click that and I'll give you the microphone.
Thank you very much. Just the last question. Sorry for asking too many questions, but because it's very interesting to me, and it's a very interesting data set actually. So regarding the coherence, do you think? Sorry, probably I missed that slide. Maybe it went a bit quickly. Was the coherence higher coherence between the frontal and the kind of occipital part of the brain, that was higher coherence in the misophonia, or it was the less coherence? Can you just maybe take through that slide again, if possible, please?
Right. But here's the global map. The conclusions from that are that the visual comparison of the coherence maps for all 9 subjects revealed no common pattern of hyper or hypocoherent, which is to say that some were hypercoherent, some were hypocoherent. There was not a consistent, there was not a sufficient number of those for us to say that, yes, it's a hyper or a hypo problem. We are beginning to get a good enough trend to be able to say that, however, if there is probably a component of misophonia that is related to coherence.
And I just want to remind everyone that the presentations are uploaded to Google Drive. I'll be sending out it's the same link as for workshop 2. And so I'll send that again out as a reminder. We have a couple more questions down here. Randy, you want to address Esther's questions?
Yeah, the one at the bottom I see, which is, do I have the references or studies or a set of abstracts you could email us, specifically related to the use of neurofeedback with misophonia. This is the only study that exists to the best of my knowledge. The other specific neurological references to misophonia are in the paper. On the slide, so if you look at the last slide where the references are, those are the ones that we can find that are related specifically to neurological seekings after. Tom's got some articles that he's posted that are in other domains that I'm not talking about here. And do I have a list of neurofeedback or Loretta providers? How accessible is the treatment for sufferers? You can go to a couple of different locations. One would be bcia.org. That's the Biofeedback Certification International Alliance. They provide the certification for practitioners who seek to be certified. They have a list of providers by zip code, state and or country to the degree that people have given us that information. And they're broken down by both biofeedback, traditional biofeedback, and neurofeedback. And ISNR International Society for Neurofeedback and Research.org, also, which is the National Organization for Neurofeedback Providers. They also have a members list that you can look at and search it by state, country, or zip code. Finding someone who has and does the Loretta Z-score training is more challenging than just finding traditional training. There's fewer of us out there doing that. And depending on where you are in the country, it can be either very easy to find a practitioner or very challenging. There's 6 providers in the state of Iowa, and as far as I know, I'm the only one who has trained misophonia. But if you get out to the east or the west coast, you can find a lot of providers.
Okay, so this is a collaboration workshop. If anyone has a discussion point you want to bring up, I'm going to bring one up, so I'm going to just mention that, and then please step in, express opinions and views of what you see and what you think. But, you know, Randy, one of the things that I noted in the 9-year-old girl is that she was much better. I mean, obviously there's been a drastic improvement and a benefit to her life, but that mom still mentioned that for her to be doing well, she has to be getting enough sleep and eating and have a general cooperative relationship with whoever it is that's the trigger person, right? Which implies that they're I'm going to just suggest that to me, one potential benefit of neurofeedback is that it improves the overall health and well-being of individuals. Right? That it improves sleep. It improves. Can it also improve mood? I'm not sure if it improves mood. But it does have global benefits, does it not?
Yes, indeed, exactly.
Right, and so with the people that I've worked with, almost universally, they will say that when they are feeling better, their misophonia is less severe. So that there's a direct correlation inverse correlation between wellness and well-being and misophonia severity. So it seems like there could also be an indirect, very positive effect of neurofeedback just by working on health and well-being, which may also be what Jamie Moore is seeing when he's working on the, diet and the, inflammation and other things that affect wellness. What do you think about that?
To a certain degree, I totally agree. All of us with whatever things we have, as our personal, gee, I have this challenge or that challenge. If we're rested, we've been eating well, we're generally healthy and taking care of ourselves, we cope better than when we're not. And clearly, we know from his long, 50 plus years of doing neurofeedback, we know that we help that for people. We help people just generally manage better. Also, when I'm doing therapy, neurotherapy, it's a one-on-one deal. I'm also talking to them. I also am coaching them in terms of ways to manage stress better, et cetera. That being said, what the study shows is that, well, indeed, we did find that the EEG changes. I didn't put any of that information up there, but we record cues all the way along. So I have what your brain looked like and how it was functioning in the electronic area from the day that you walked in, and then I have it again from the last day you see me. And so we can show that we, in fact, have changed the EEG, that they don't have the same brain leaving that they had coming in. And we can associate those changes with the kinds of regions in the brain that the symptomology is associated with. So executive control has improved. The auditory circuits are functioning better. The abnormalities that we saw in the parietal or the occipital lobe are lessened or have changed. So I think the answer is both and yes. Yes, we help them just manage better, and yes, we're also changing the brain, which I think is responsible for, in many cases, for the diminution of the symptomology.
In the individual that did not respond with with reduced misophonia symptoms, did his brain also
We saw
change?
changes in his EEG. Particular individual is complicated.
Yes. And those of us who are involved in treatment of people with misophonia know that this person's case is complicated.
And so, you know, it isn't my hypothesis for why we did not ultimately get the changes that we anticipated, specifically the misophonia, is some other conditions that pre-existed that we were working on. I mean, I think we made some progress in there, and I think his overall life function is improved in part because we were able to do that. You know, yeah, he's a complicated case.
He's a complicated case. There was a question about mindfulness being incorporated. I have found that progressive muscle relaxation is particularly beneficial for individuals with misophonia because it develops the neurological connections to willfully relax muscles in your body, and that whenever a person is tense or triggered or stressed, to be able to relax, for them to be able to relax their muscles has a positive effect on their misophonia. And so I personally would recommend progressive muscle relaxation because it produces essentially an equal level of overall relaxation and stress reduction, but it also builds the skill to be able for the person to just go relax and just relax the muscles in their body. And I find that it's a good component to any kind of treatment.
I'd agree with you 100%, Tom.
Okay. Other questions? We're out of time here, but do we have a last question or so? Otherwise, we will say, Randy, thank you so much. Wonderful presentation, great information. We just need to know more, right?
We got to just keep searching.
We need more. So, okay. So thank you, Randy.